Good evening, everyone. Myself, Dr. Sonal Mehta, Lead Medical Advisor, Intas. Being a knowledge partner and science-driven company, again, we at Intas Health Team, Women Health Team, headed by Mr. Satpathy, have organized this webinar on demystifying sexual wellness. I welcome you all to this webinar given by eminent faculty, Dr. Sunil Jindal. Dr. Sunil Jindal is MS, DNB, MNMS, is Scientific Director, Dr. Madhu Jindal, Memorial Test Tube Baby Center, Meerut, Vice President, Delhi ISAR, Delhi IAGE. He has to his credit more than 75 awards from different organizations and many publications and presentations. He has published chapters in 8 textbooks and over 200 national and international presentations. His special interest is ART, andrology, and gynecological laparoscopic surgery. I am without taking much time. I welcome you, sir, and over to you, sir.
Thank you very much, Dr. Sonal. Thank you so much for the kind introduction. And so thank you very much. Thank you so much for the kind introduction. And today, in the 5th section of testosterone, I'm going to speak about sexual medicine and male sexual medicine. Male sexual medicine, if you ask me, is one of the most complex, one of the most enigmatic, one of the most difficult, and one of the most confusing areas to talk about or to discuss. And why is it so? Why is sexual well-being of the man or the woman for that matter so grossly non-understood? I would like to first of all bring that area to you. Next, I'd like to bring to you what is sexual well-being. Third, I'd like to get across to you what are the problems with men, how can they be diagnosed, and what is the treatment, and how is it correlated or interrelated with the whole well-being of the human being. This is exactly how I plan to go about for this particular topic. But there is one thing which I always would like to say at the moment. And you know what I would like to say? एक कुमार विश्वास की बहुत ही खूबसूरत, बहुत ही सुंदर एक पंक्ति है कि ना पाने की खुशी है कुछ, ना पाने की खुशी है कुछ, ना खोने का ही कोई गम है। ये दौलत और शोहरत सिर्फ कुछ जख्मों का मरहम है। अजब सी कशमकश है रोज जीने में मरने में, अजब सी कशमकश है रोज जीने में मरने में, मुकम्मल जिंदगी तो है मगर पूरी से कुछ कम है। This is exactly the way a man feels about his sexuality. And this is how I would go ahead and bring across to you the presentation on sexual medicine and sexual well-being of the male. So I would begin my presentation on this topic, which is very interesting. Because one thing we need to understand is that the male is a gender which has a reputation to be logical, stable, unemotional, except in his sexual judgment. And Oscar Wilde says something very beautiful about the man. I can resist everything except temptation. So we need to understand this a bit further. Now what happens is with men are very different from women. Women talk to each other. They discuss each other. If there is a problem, they would share it with everybody. And they would say, सबसे बात कर लो, dil halka ho jayega. But this is not the way men are. Men don't have many resources available to learn about themselves. And unfortunately, about sex, the only resource available and freely available is the wrong resource, which is the internet, which more than making you understand something, puts you into an area where you wonder, I am inadequate. The second thing is, men certainly do not share much about themselves with others. And this presentation will tend to clarify actions and reactions which men have, which are vague and confusing. And there is a lot of neglect in this area of human existence, which I would talk to you about. Now, I'll also tell you something very interesting, that men, unfortunately, just want to be normal. But the definition of normal for them is very unfounded. So you know what happens when patients come to me and they tell me, I am not like before, मैं पहले जैसा नहीं रहा, or they try to compare themselves to somebody about whom they have heard something crazy. More than understanding their own sexuality, they say this is normal and this is not normal. There was a very big study in 2013 in which it was estimated in the normal population, 35% of men and 54% of women feel they are inadequate. Now, what is sex? Sex for the public means the internet. It means naked men, naked women, coupling. So this is what sex means for the public. For a physician, normally sex means they're wanting to have babies, and why are they not having babies? AIDS, sexual medicine, and along with that, it means to them sexually transmitted diseases. To most of the population of this country, it means a taboo and constraints because of social regulations. I'll give you a small example. It's about 10 or 12 years back. I'd gone to a very senior citizen, about 60, 65 years of age. He was watching television. And incidentally, he flipped on Tata Sky. At that time, it used to come, Fashion TV. So he was watching Fashion TV, and I went and sat next to him. You know what he said? He said, "Pata nahi zamana kaisa ho gaya, kaise kaise channel chal rahe." But he did not flip away from that channel. How bad the society has become because they're having channels like this was his next conversation. But he did not flip the channel. Just understand. This is the rigid social regulation and taboos which we live in. Now, what does an anatomist do? An anatomist, for him, sex means only two alternatives. Either you're a man or you're a woman. But at the most basic level, if I talk about it to you, sex is a genetic recombination. And it is a hormonal, neurological, endocrinal, and physical culmination of the whole human being, which needs to be accepted as that human being is to all of us in society. And if it is accepted, then the problems of sexual corruption, as they call, go away. Now, why is sex so misunderstood? Because no one knows the history or the chemistry. I'll give you a small example. There's so many times that a child, small child, has an erection and the mother says, "Gandi baat hai." There is some problem with the child. And at times, I've had mothers bring their children and say, "Sir, is time par bhi iski susu mein problem hai." And they feel it is something bad. They tell the child, "Please do not touch over there." And the child starts only thinking about that and nothing else because they're not comfortable with it. And this is the kind of misunderstanding which creates two deep-rooted problems which decrease the sexual well-being of human beings. Now, sex initiates adolescent rebellion. When a child grows up, his hormones change or her hormones change. They lead to a rebellion. And the mother says, my child is not like before. So the father says he's growing up. There are a lot of things like jealous rage, romantic fantasies, recklessness. And all these things are related to the sexual chemistry and the way the human being grows. The other question comes is, why is sex such a powerful and mysterious force in our lives? Now, I very simply will like to demystify or unravel it to you today in the form of hormones, in the form of what actually happens. So let us try to understand male sexuality. Now, there are a few questions which always people ask. And these are questions which every mother asks, every wife asks, every woman asks, every man asks. And these are questions which I'll talk out now to you. Why do newborn babies have erections? Why do young boys play with their organs? Why do adolescents sleep more in prone position? Why do teenagers need more space of their own? Why do people fall in love and have a crush? Why do men go weak in their knees when they see a beautiful, attractive, and sexy woman? I'm sure most of the men have felt this. And why does their entire body, language, music, and behavior change when they see a beautiful woman? Why do men have extramarital affairs? Why do sex lives become boring and tedious in middle life? Why does sexual inadequacy of the 40s and 50s play havoc with your confidence and emotions? And why do men, even in the age which is further on, still have sex on their mind? These are questions which every human being asks. Now, this I would like to explain to you is the chemistry which goes on in the brains of a woman and a man. So we need to understand these hormones. So the most important hormone of the man is testosterone. So what happens with testosterone is that this is the hormone which rises with dopamine when a human being falls in love or he likes a woman. When a man sees a beautiful woman, dopamine goes up, shoots up. And along with that, testosterone shoots up. It leads to a sexual overtone. It's responsible for his aggressive sex drive and erection, and further on, the way he behaves. The other hormone which you have is estrogen in a woman. The estrogen not only makes a woman receptive from the point of view of the uterus and the cervical fluids, the estrogen hormone also makes a woman the woman receptive to the man whom she wants because of dopamine and a combination of oxytocin. Now, progesterone is a natural sex offender. So when progesterone rises, it kills the sex drive. So this is what happens. At the time when a woman ovulates, she's ovulated, and after ovulation, what rises is the progesterone. So what rises during ovulation is estrogen. So during ovulation, she naturally wants to have intercourse. And the moment she's had a time when the fertile time has gone away, progesterone rises and she doesn't want to have intercourse. Now, oxytocin is the human superglue. It's crucial for the bonding and the feel-good hormone it is. Serotonin is the kind of hormone which happens in the brain, and it makes and changes the way you look at sex. And this is one hormone which also is very important for the time which a man lasts during intercourse. Now, vasopressin. Vasopressin is a hormone which you could call a monogamy molecule. A molecule which is going to temper the influence, settle a man, and manage his testosterone. Prolactin is the hormone of nursing. When a mother feeds, the hormone which leads to lactation is prolactin. And when it rises in a man, it leads to him becoming impotent. Dopamine, of course, is what rises when a person takes cocaine, when a person takes drug, when a man falls in love, when a human being says, wow, I am so happy. That's dopamine. Now, DHEA and DHEAS S leads to sex appeal, sex drive, and the orgasm. Pheromones are sexually transmitted through scent, and while direct courting and mating, there are those feelings when a human being says that, well, आपकी जुल्फों की खुशबू मुझे दूसरी दुनिया में पहुंचा जाती है. कितने सारे शायरों ने बात की है उन खुशबुओं और अदाओं की. These are pheromones. And phenyl ethyl amine is supposed to be the romantic part chemical for love. Now, there's so many chemicals which get together to bring about of how the human being behaves. But this is all very natural. It is nothing unnatural. See, we naturally need to understand that this is a natural process to be accepted by every human being. Just like we eat, drink water, and we accept eating and drinking water. Similarly, the sexual well-being, the basic thing of a sexual well-being is acceptance, which is very important. So in this outline, we're going to talk about a short introduction. What is male sexual dysfunction? What is the role of testosterone in male sexual dysfunction? And kind of summarize the whole thing the way it is. So we all know very well that male sexuality is a complex physiological process, an important part of quality of life. And we know that it's a coordination of the nervous system, the cardiovascular system, the endocrine system, and the reproductive system. So all these systems together bring about what we know as male sexuality. Now, there are two parts which people confuse, an orgasm and ejaculation, and there are two different processes. An orgasm is an intense, transient, peak sensation of intense pleasure of an altered state of consciousness associated with reported physical changes. If you have read a lot of spiritual literature, they talk of an area where space, time, and human beings become same. And that time is known as the top meditative level. A shorter level of that, not to be, of course, equated, पर वो आनंद की घड़ी, if I could call it, could be an orgasm. But ejaculation is a different process altogether, and it has two phases, emission and expulsion. And these are intricate, neurological, governed, and hormonally governed processes, which I will talk to you about. So what we need to understand is that there is excitement, there is a plateau, then there is an orgasm, and then there is a resolution. Now, the problem for a man can happen in any of this process, and this needs to be understood. So this is the gross anatomy, if I would bring it here. And this anatomy, you would see that you have the prostate and the seminal vesicles, which have the semen. You have the external urethral sphincter. You have the bulbocavernosus muscle, which contracts to give ejaculation. And you have the corpora cavernosa and the corpora spongiosum, in which the neurological, the cardiological or vasomotor functions along with the hormonal and the brain come together to give you the erection. The sperm comes from the testes, which via the epididymis reaches the prostate to go ahead and get mixed with the semen. Now, age has a very big correlation to erectile dysfunction. So there is a 50% probability of a man having erectile dysfunction at the age of 65 to 70. And at the age of 40, there is about 25 to 30% probability. Now, this is what happens. So the man compares himself to when he was 20 years old. And he comes to you and says, I have erectile dysfunction because I cannot function the way I was earlier. So this is the area where age has a very major role. Now, what is the mechanism of erection? The mechanism is simple. The corpora cavernosa and the corpora spongiosum have sinusoids which get filled by arterial dilatation. Blood fills in them. Once bloods fill in them, they become larger in size. The outflow stops. So just like in a sink you pour in water, the sink fills. And when the sink fills, the stopcock is closed. Similarly, the penis gets filled with blood in the sinusoids. The outflow gets blocked and there is an erection. See, normally what happens is that normally you would have blood flowing in and an open outflow. So this would be the passive state. Now, in erection, arterial blood flow increases. Sinusoids get filled. The tunica gets together. It compresses the venous outflow, which gets stopped. And there is an erection. Now, you have to understand that the endothelial vessels of the penis and the endothelial vessels of the heart are the same. So if cholesterol gets into your heart vessels and gives you a heart attack, cholesterol also gets into your pineal vessels and leads to atherosclerosis. So it is seen that men with erectile dysfunction have twice the chances of having a heart attack. And the risk is similar to smoking or a family history. Now, erectile dysfunction is very common. It's a marker of heart disease. It's related to the overall health. Eating, sleeping, stress, exercise, they have a function on it. And you need to get your testosterone right. Now, I'd like to bring a few statistics to you for you to understand that endothelial dysfunction appears to be the final common pathway for many cases of erectile dysfunction. And 2/3 of men with hypertension have some degree of erectile dysfunction. ये फोन उठा के कहना कि वो लेक्चर ले रहे हैं. 60% of men presenting with erectile dysfunction had undiagnosed lipid abnormalities. And more than half of men with erectile dysfunction who have no cardiac symptoms have an abnormal stress test, and 40% have found to have a significant coronary artery disease when studied. Of the men hospitalized for the first myocardial infarction, 64% had ED with onset 3 years or more before infarction. So it is very important for us to understand that we as human beings need to see the close correlation, and this close correlation is most important. So when a patient comes to me, what are the questions which I normally ask? I would normally have 5 questions on which I would like them to answer and give themselves marks 1 to 5. So first is, how do you rate your confidence that could get and keep an erection? Next is, when you have erections with sexual stimulation, how often were your erections enough for a penetration? During sexual intercourse, how often were you able to maintain your erection after you had penetrated or entered your partner? And during sexual intercourse, how difficult it was for you to maintain your erection to completion of intercourse? And when you attempted intercourse, how often was it satisfactory for you? Now, if the score is less than 21, it would indicate some form of an erectile dysfunction. You could take a picture of this. This is very useful, and I think you should use it in your clinics in case you get patients. How did you like it? I'm sure you did. I'll now come on to the next slide, and the next slide is interesting because this next slide is a beautiful correlation of erectile dysfunction and medical conditions. So in people who have severe depression, there is a 90% chance that there is erectile dysfunction. Post myocardial infarction, anybody has a heart attack, there is a 40% chance of them having erectile dysfunction. Diabetics, 35% have erectile dysfunction. Hypertension, 25% have erectile dysfunction. And 20% of cigarette smokers have erectile dysfunction. Isn't it interesting? Please type in bulb on, BO, into the chat box. Just type in BO into the chat box. It's so interesting. So any patient who comes to you, and you know something interesting, 46% of people who have sleep apnea have erectile dysfunction. So they say they are tired in the morning, they do not know whether they are breathing well or not, they are fat, ask them. They have erectile dysfunction. Now, these are the hormones I was talking about, which I have spoken to you about. But we need to understand that thyroid is also a hormone to be looked into. And of course, the most important hormone is testosterone. Now, this is the pathway which, if you understand slightly, it would make you understand the chemical pathway in the penile arterioles. So what happens is that the main chemical, which is nitric oxide, it leads to decrease in intracellular calcium, which leads to relaxation of the sinusoids, and blood fills in and there is an erection. The same thing is done by VIP and prostaglandin E1. So whenever prostaglandin E1, VIP or nitric oxide are there, we all know we give arginine to these patients because arginine is a precursor of nitric oxide. And when it leads to a decrease in the intracellular calcium, it leads to relaxation and erection. But on the other hand, when circulating noradrenaline rises. When there is sudden fear, sympathetic sixes goes on. It leads to increase in the intracellular calcium, and this leads to contraction and flaccidity. So you will understand it further on when I go on. Why is it important? Then you have the role of the nerves. So the central nervous system, the spinal nervous system, the sacral local plexuses, the nerves which go to the dorsal nerve of the penis, the pudendal nerves, and the efferent perineal nerves which go to the bulbocavernosus, they all have an electrical system which functions. And testosterone has a part in this through the central and peripheral androgen receptors along with the nervous system. I'll just explain you how. So now what happens is the brain has different areas which have emotions, audiovisual stimuli, fantasy, hormonal environment. All these things together lead to excitatory or inhibitory messages. Now I'll give you an example. Now these excitatory messages from the parasympathetic circle arc lead to an erection. I had a patient who came to me and said, I always have an erection when I go to my girlfriend, but I never get an erection with my wife. I have erectile dysfunction. So somewhere, of course it was psychogenic, but somewhere in the brain, the emotions with the audiovisual stimuli bring an area down the spinal cord which gives inhibitory messages, and instead of stimulating the arc, the local arc, which is the parasympathetic arc, which leads to erection, it stimulates the sympathetic arc and leads to flaccidity. Now, if there is no emotional stimulus, still a local stimulus can give an erection. Like so many times we have patients who are impotent and we use a massager to get an ejaculate if they are infertile. And all that they actually need is the vibrator on the glands and the frenulum. So this local, particularly local stimulation leads to an ejaculation by the reflex local arc. There has nothing to do with the brain. So now this is what happens, that whenever there is an inhibitory stimulation in the brain, it leads to release of systemic catecholamines and inhibitory signal via the spinal cord, which leads to detumescence. So now male sexual dysfunction is you can divide it into three areas. It could be decrease in libido, erectile dysfunction, and ejaculatory dysfunction. Now, I'll give you a few statistics that are interesting. That an Indian study which was done in 2015, it showed that 21.15% of male subjects, which were even young people were taken into that, had sexual disorders. So about 1/5 or 1/4 of the population. There was erectile dysfunction in about 15%. There was premature ejaculation in about 9%. And there was male hypoactive sexual desire in about 3%. This is even the young population. Now, hypoactive sexual desire. You've got so many men who say that they just do not have persistently or recurrently, they have deficient or absent sexual fantasy or desire for sexual activity. So this patient of mine who came to me recently, he said he was absolutely fine. but now there is just no desire. So I asked him, what about the erection? So he said, how can I have an erection when there is no desire? So when I asked him if in the morning he had erections, to which he said, yes, which meant he had a hypoactive sex desire, but not erectile dysfunction per se. So it's generally estimated that 15% of adult population have hypoactive sexual desire. And it could be because of depression, medication, illnesses, testosterone deficiency, or psychogenic causes. Now, low testosterone is very commonly associated with low libido and can be treated by testosterone replacement therapy. But it is only to be used if testosterone is low. And men with erectile dysfunction may experience loss of libido as a secondary consequence to erectile dysfunction. Now I'll explain this to you. Men are very sensitive creatures. They have a phenomenal amount of performance anxiety. And like women have anxiety when they go to parties, whether they're looking good or not, are people loving them or not, are they attractive or not, are people saying I'm looking good. Men deep down have a very crazy thing attached to their brains, that their complete manhood is dependent on their erections. And if they do not have the erection the way they want it to, one time or a couple of times, they get upset. And that in the other way leads to a loss of libido in these men. And these men, when they give you a history, they would tell you, I feel very tired and I don't feel like having sex because I am tired. When you take their history further on and ask them if they have had any kind of an erectile dysfunction, then they would tell you that they love to see movies, they love to read books, but because of the fear of performance, they feel this is not their cup of tea. So history needs to be taken. Now I come to erectile dysfunction. It is also known as impotence. And it is defined as the persistent inability to attain and maintain an erection sufficient to permit satisfactory sexual performance. And it has been estimated that between the age of 40 and 70, at some point in their lives, 52% of men have erectile dysfunction. Now, what are the investigations which you would get done for them? For these men, you would like to get done a fasting glucose, a lipid profile, and a hormonal profile. Along with that, please get a thyroid, a PSA, and prolactin. So these are the tests which you normally would like to do in all men who come to you with erectile dysfunction. Now, along with that, I have just mentioned over here, you could do an intracavernosal injection, which could be done by papaverine alone, or papaverine with phentolamine, or with prostaglandin. And once you inject it, you would like to see of what kind of erection is present, because see, when you inject, it tells you about the vasculature and it bypasses the hormonal and the neuronal circuit. So if there is a problem in the vasculature, you would come to know whenever you would inject. Now, the second, of course, is a penile Doppler. This is a beautiful investigation because it's non-invasive. And in case after injection of papaverine, the peak systolic velocity is more than 35 centimeters per second, it means that the arterial flow is fine. However, you need to see the venous flow. And if the venous flow is more, it means that the arterial flow is fine, but because of the larger venous flow, erection cannot be maintained. So which means there is a venous leak. And this can be corrected by surgery. So like in this patient, you would see that the peak systolic velocity is 40 centimeters per second. But with a peak diastolic flow of 5 centimeters per second, there is a venous leak. And you could also see the dorsal vein of the penis and see what is the flow in that. And any enhanced flow over that would tell you there is a venous leak. So it's a beautiful investigation to see the vascular Can you hear me? Can you hear me? Give me
Yes,
other
sir.
phone.
Yes, sir.
Is
Sir, it's stuck.
some problem with the net over here?
Okay. Now we can
Can-
hear you, sir. We can hear
Can
you
you
now.
see?
Yes,
Can you?
yes.
You can? Okay.
Yes,
So
sir.
I'll continue. I'll continue. Please be with me, somebody, so that
Sure.
I could know. Okay.
Yes.
Please. I'll just do the screen sharing. So now next is when we do these color studies of arteriography. I normally do not do it, but I have seen them being done, are done at times where surgery is used phenomenally. These are the areas where this is used. Can you just dial lay this eye? Lay this eye ka number below. Now let us now come to premature ejaculation. Premature ejaculation is when a spectrum of disorders are there. When there exists a spectrum of ejaculation ranging from mild premature to severely retarded or absent ejaculation. And there are several studies which have estimated the prevalence of this to up to 29%. Now, I would now talk to you about what are the different things which we see. There are two types of erectile dysfunction which we need to diagnose. One is psychogenic and the other is organic. So earlier it was thought that 80% of the problem of erectile dysfunction was psychological. It is not so. So you have two types. One is psychogenic, which is sudden of onset. Organic is very gradual. There is a specific situation. So a man says, I just cannot have intercourse with this person and I can have it with other people. This is psychogenic. Now in psychogenic, there is normally a normal erection in the mornings, which is absent in organic. And there are relationship problems or psychological problems, problems with sexual development when you ask the history in psychogenic. And there is normal sexual development in organic. Now we need to understand, and you have to diagnose this. You have to diagnose this whether the erection is psychological. It could be because of any previous sexual abuse, psychological trauma, performance anxiety, relationship problems, problems with intimacy, depression and guilt. And all these together lead to psychogenic erectile dysfunction. So you need to diagnose it, because psychological or psychogenic erection dysfunction needs some psychotherapy. And of course, once you give to these patients a PGE5 inhibitor with psychotherapy, and they're going to have intercourse for a couple of times, things become okay for them. Now, these are a lot of things which I have brought into, but in a nutshell, I would say that the disorder onset, the precipitating event, the erectile function before entering, whether erection stays after, nocturnal and morning erections, whether it is sudden or late onset, whether it is associated with an ejaculatory disorder. With psychogenic, a lot of these men have premature ejaculation, while with organic, a lot of these people have absent or retrograde ejaculation. They would let you know whether it is organic or psychological. Now, what is the aim of therapy of men with sexual dysfunction? So the aim is to improve libido in men and to address two vital sexual functions: the capacity to attain a good erection and to make it stay on and prevent premature ejaculation. Now, you need to see the drugs, whether the person is taking any antidepressants or antihypertensive. You also have to check the cardiovascular risk. So, how many of you have treated patients of erectile dysfunction and found cardiac problems? Just type in the chat box I. Just type in the chat box I if you have found men who have erectile dysfunction and have had cardiac events. I've had so many patients, and therefore I'm very particular about getting a cardio evaluation of these men done in case the lipids are haywire. I make it a point. So this is something to be noted by you. Now, what is the approach to the management? Now, the approach to the management is you take the history, you ask them for a lifestyle change, which is weight loss, exercise, tell them to stop smoking. The benefits of everything need to be explained to them. Call the wife, speak with the partner. You will really understand the truth when you talk to the woman. And you give these patients something as a PD5 inhibitor. See the response. They could use vacuum devices, which are very useful. You could give these patients intracavernosal injections. Intraurethral alpha prostatal is not very easily available in the country, so that is not something which you can use too much. And in case all of them fail, then you may need to give these people a penile prosthesis. Then you assess the outcome, see how they are feeling, and assess the dose which needs to be given. Now, something very important, which is magic. And what is magic is the drugs which are the phosphodiesterase 5 inhibitors, which are sildenafil, vardenafil, tadalafil, and avanafil. And sildenafil is the first in line, which was discovered as Viagra, the blue diamond. And this changed everything. And the guidelines of the American Urological Association are that they are the first line treatment of ED. The European guidelines give you the choice of the product to be used on the frequency of intercourse. So if there is very long time frequent intercourse, you could give these patients tadalafil because the half-life is long. And if the human being just wants to go ahead for a single intercourse, and whenever he goes in for intercourse takes or wants to take a drug, then sildenafil or Viagra is the best drug to take. Now, why are they good? Because they produce a natural erectile response to sexual stimulation. See, you need to understand, if there is no sexual stimulation, Viagra will not function. Viagra does not do anything to libido, and it enhances the relaxation effect of nitric oxide on corpora cavernosa. So whenever you give a patient Viagra, you need to tell them that this will only function when there is sexual stimulation, and you also need to counsel the partner about it. Now, it has a very broad spectrum etiology, so it functions in a lot of different conditions, so it can be used. And there is no evidence of drug tolerance with this, that today I'm giving 50 milligrams and I will have to enhance after some time to 100 milligrams. No, it's nothing like that. You need to titrate the dose, but once you have titrated the dose, then whenever and whatever quantity you need to give to them, you can give to them the same quantity. There are side effects, but they are predictable, it's well tolerated, and dose dependent side effects. So it's a relatively safe drug to use. But the problem is, this drug is used now as a recreational drug. And that is the problem. And using it as a recreational drug can lead to phenomenal side effects. So it is a drug for treatment. It is not a recreational drug. Now, this is a cycle which I'd like to explain to you. In this, what happens is that the cavernous nerves release the nitric oxide, and this nitric oxide changes the guanosine triphosphate into the cyclic GMP. And this cyclic GMP gets degraded into GMP, which is guanosine monophosphate. Now what happens is PGE5 leads to the degradation of cyclic GMP to GMP. So these inhibitors, they lead to the inhibition of PDE5. And this leads to more cyclic GMP, and this leads to a better erection. This is how it functions. So we need to understand two things. You need stimulation for the release of nitric oxide. Arginine, as it is given, is a precursor. If this is not released, this does nothing. So release of this is important for this to function. So libido is important and desire is important. That is not got by Viagra. But do you know where it comes from? It comes when the testosterone is normal. So what you need beyond this is a normal testosterone. So a lot of men in whom PGE5 does not function, if they have a low testosterone and they are given testosterone, this starts working. So this is the basis of this. It's a very complex system, which I could talk 2 hours to you about. But I have very simply tried to bring it to you, which practically you will understand. This is the intrapenile injection, which we use in a lot of patients. And in patients who do not respond to PGE5 or have a poor erection with PGE5, we normally would use a intracavernosal injection. Now, testosterone, it acts on organic, intracytic, and relationships of erectile dysfunction. In hypogonadotrophic, we need to give a hormone replacement, and libido and the overall self well-being enhances when you give testosterone to a man who has a low level of testosterone. So in the last lecture, I had talked about the hypogonadotrophic hypogonadism, where I had spoken to you about how these men are listless, feel tired, have a low libido, have erectile dysfunction. You need to give these men testosterone. And if any man is there who is above 40 or 50 years of age, who comes to you of erectile dysfunction, please get the total testosterone tested. If it is less than 300, get a free testosterone done. Between 300 and 350, if it is there, get a free testosterone done. If it is low, give these men testosterone gel, which is the best to give. And if it is lower than 300 as a total testosterone, they are candidates for testosterone replacement therapy. Now, I have this slide over here for us to understand that testosterone levels and symptoms come in the form of loss of libido, loss of vigor, the first. First, loss of libido comes. Then these men become overweight. Then they go into depression. And the last is erectile dysfunction. So when you replace testosterone, it comes back in the same fashion too. So the earliest to get fine is libido. And the close to the last, to get fine is erectile dysfunction, obesity, and of course, the bone density. Now, testosterone replacement therapy, there are three options: oral, injectable, and transdermal. I have given oral for a very long time. I used to give injectable till about 4-5 years back. But now, from the time the gel has come, I have started using gel because of two reasons. Number one, the plateau is the same. There are a lot of peaks with testosterone, and it is more physiological. It does not affect the liver, and it does not affect the electrolytes. Now, how do you normally give a gel? One actuation has about 12.5. So normally what I would do is, I would start with 4 actuations, which would be 50 milligram. And I would give these men 50 milligram daily for a period of about a month. Measure the testosterone after a month. If it has come in the mid-normal range, I keep this as the dose, or I enhance it to 6 actuations. And from 6 actuations, if it maintains on that, I keep it on that, or the maximum which I would normally give is 8 actuations equal to 100 milligrams. But please do not give this if the testosterone level is normal. And please do a baseline PSA in the man before you give this. So it enhances and changes the sexual desire, erectile function, as well as the sexual satisfaction. There are a lot of studies which I can speak to you about, loads of studies, but I wanted to give you a nutshell of this instead of going into I have about, I think, 22 studies which I can explain to you. where it is useful, but I have tried to give you the nutshell of everything, because we we already have gone into a time where it is very I mean, we have exceeded our time. I think I thought I'll speak for 45 minutes, but there are a lot of other things to be spoken about. So this is the summary of erectile dysfunction, but I have kind of made you understand a lot of things. But now let us come to premature ejaculation. Now, premature ejaculation is something which is very distressing to men. And ejaculation which occurs or nearly always occurs before 1 minute or within 1 minute of vaginal penetration is premature ejaculation. And the inability of a man to delay ejaculation on all or nearly all vaginal penetration is a part of premature ejaculation. And negative personal consequences such as distress, bother, frustration, and avoidance of sexual intimacy are parts of premature ejaculation. I have this small video. I hope it plays. I just got it from WhatsApp, but it was interesting. So I thought I'll place it here. So if you ask me, it's a very distressing thing for men. And you have two ways you can treat it: by behavioral therapy, the start-stop technique, squeeze method. There is a exercise in masturbation which they can do. And these were the man who found them were a team, Master and Johnson. And let me be honest with you, there were two researchers which have given so much to sexual and well-being and health. Or you could give these people drugs, which are SSRIs. And these drugs, the short-acting drug which has become very popular now is depoxetin, which is on demand 30 milligrams in 1 to 2 hours. But a lot of men who have very severe premature ejaculation, they need something like paroxetine. And I have been given sertraline and paroxetine for a long time to these people, and the results are very good. And it normally starts acting by about a week. You have to titrate the dose, and you have to tell the person that initially he may feel a bit drowsy, but then this drug helps in premature ejaculation. You can also give these people tramadol, and tramadol helps in premature ejaculation. Topical cream like anesthetizing creams, and a lot of condoms which have come up now which say are long-lasting condoms, they normally have something like prilocaine or xylocaine, which is used to decrease the sensations. They can be used. Now, I wanted to bring to you a few surprising facts. So please type in the comment box, BIO, bring it on, because these are phenomenally surprising facts which I have put in after so many years of clinical practice from what the patients come to me. So first thing which I have realized is, and this is a fact, surprising fact, that most men with ED actually don't have ED. They either have less desire after a particular time where they need testosterone, and once the desire is up, it is not ED. The second thing which I found is a lot of men compare themselves to previous as they were, and they think now it is ED, it is just an age-related change. So this is one thing, and it's a surprising fact. The second surprising fact is penises are fragile. I have seen so many fracture of penises, which normally happen because of different positions which people take, especially the woman top position when she slips. And this leads to penile fractures, and if not treated properly, it leads to lifelong impotence. So you need to be very cautious with men, and to a lot of men you have to explain about the fragility and the fact that fractures can take place. The second thing is erections happen very early in life. In fact, even in the womb, the fetus has erections. So please, if somebody comes to you and says, my child has erection, you need to explain to them as pediatricians, it is normal. Next, medications do not always work in ED. And please ask your patients not to use Viagra as a recreational drug. There are loads of patients who come to you and say, I have a very short penis. The increase in size on erection of a short penis is normally 87%, and the increase in size of a large penis on erection is only 43%. So please let them know they should not get so distressed. The average size of erection of a penis is 5.6 inches long, which you need to tell these patients. And nowadays, the movies and more than that, the internet has done something very, very criminal. It has made a lot of men self-doubting. They should know that the largest world record till date is only 13.5 inches of a man who was 9.5 inches on flaccidity. And erectile dysfunction can signal a serious health problem, and the normal duration of intercourse is only 3 to 5 minutes. There are no supermen who go on for half an hour. I recently had a patient I'll tell to you about, because it's very, you people should understand as clinicians. There was this man who had a second marriage, and he came with his wife, and his wife had taken an appointment, and she said, there is something very majorly wrong with my husband, and my husband doesn't last more than 5 to 7 minutes. I took the history of the husband, and the husband said, everything is fine for me. So I asked the wife, what is the duration? And the duration was 5 minutes. So I had to explain to her that the normal duration is 3 to 5 minutes only. And whatever today we come across, which we call as our sex education, is something which is creating a lot of problems for human beings per se, and creating issues with their sexual well-being. So with this is Priapus, the Greek god of lovemaking. And on this note, I would like to say thank you. And I really hope you got a lot out of this talk to be used with your patients. And thank you very much for you being over here for so long. And thank you very much for that.
Thank you, sir, for giving very insightful and rather practical talk on this tough topic. And all the viewers have enjoyed this, and they are telling it was fantastic. There are many questions. I will take some of them, if you permit.
Yes, please.
Yeah. So a patient who married 5 years back but still not able to do proper sex with wife, patient can masturbate without any issue. How can it be treated?
Now, see, you have to understand, it's a very interesting question. Non-consummation of marriage is a very big subject which you can speak about. And I, about 5 years or 7 years back, was in a conference where I was on the panel with 4 of the top experts of the world, urologists from Europe and United States. And we were discussing, they had never seen non-consummation of marriage. One of them had never seen non-consummation of marriage, while we see non-consummation of marriage so often. So if a man gets an erection, he can masturbate, and he's not able to penetrate, it means simple, it's psychogenic. And this psychogenic problem stems from some kind of a sexual hangover which the man has. And similarly, it is with vaginismus. for women, because my next topic is going to be the sexual wellness of women, demystifying. That also is going to be probably 1 hour. We were earlier planning of speaking on both the topics today, but they would be so long that we would not be able to speak about it. So I'll talk about it later. So most probably it is psychogenic. You will have to call both of them and counsel them. Please get all his hormones done. You could give this patient an intracavernosal injection. Because of that, he's going to have an erection which will last about 15 minutes to 20 minutes or 30 minutes. You could ask them and go and have intercourse after that, if they are not able to have with a tablet of Viagra. And in case they're able to have it once, then they would know they could have it other. So it's important for you to do that. Also counsel the wife and check if the wife has vaginismus. Sometimes what happens is the woman has vaginismus, and because of vaginismus, the man does not have intercourse, and he starts having psychogenic impotence because he loves that woman and he is not a rapist. Please understand. And therefore, because of this reason, men become psychogenic impotence in vaginismus. So it's a very detailed history you need to take of both of them. Go ahead and treat them. 99.9% they should be fine.
32 years old male, all hormones normal, has erectile dysfunction. How do we proceed?
Have you got his hormonal profile done?
Sir, they are telling all hormones are normal.
Did you get the lipid profile done?
So they have not mentioned it.
No.
I think they have not done.
So what you need to do is get a lipid profile done, get a blood profile done, check with he's diabetic or not, check along with that if there is any lipid problem with him or not. If there is that problem, start treating that problem. Give these patients PGE5 inhibitors, see how the response is. Speak to both the husband and the wife, make them comfortable. If PGE5 doesn't function, give them a vacuum with it, let them use a vacuum. And if these don't function, then you could go ahead and give an intracavernosal injection, and where you could teach these people also intracavernosal injections.
One question is, if a person has both premature ejaculation and erectile dysfunction, which is to be treated first? Combination of pharmacotherapy for both of these is it ideal, or should be treated on priority basis?
It's a very good question. So first you have to diagnose whether the person actually has erectile dysfunction or premature ejaculation only. Most of these men who have erectile dysfunction, you need to ask them whether they discharge at the time when their erection goes down. Because a lot of time, these people with erectile dysfunction don't get an erection at all. And a lot of these people, when they have erection and the erection goes down, they do not discharge. So you need to ask them whether they ejaculate or they do not ejaculate. And after taking this history, you would be able to understand whether you need to treat them for ejaculation dysfunction only or with premature ejaculation. You can give them drugs for both. It's not a problem. But the most important thing is, you, after taking history, seeing if these patients' hormones are normal, seeing if their general well-being is fine, if they are smokers, getting the smoking stopped, then you have to diagnose whether it is both or it is one and treat accordingly.
So there are many questions, but I am taking the last one. Any role of testosterone in premature ejaculation?
Not really. Not really.
Right.
So see, testosterone is a drug which enhances the libido, and it is a drug which enhances the desire. It is a drug which enhances the release of nitric oxide. It is a drug which has androgenic receptors which also lead to neural stimuli. And in case PGE5 is not functioning and the person is hypogonadotrophic, this drug helps, especially giving gel to these men. So that is where you would use it, or I would use it.
And sir, it was a very wonderful talk, and they are telling it was a master class.
Oh, thank you. Thank you very
Yeah,
much.
an excellent talk.
Now I am going to have the next lecture, which is next Saturday. And next Saturday, the lecture is going to be at 5 p.m. And the lecture is going to be on sexual well-being of women demystified. In fact, women are even more complex than men, not in every other fashion, but in this place too. So it would really take me a lot of mental thinking how to simplify and give it to you for you to understand and treat your patients. And once again, love you all. Thank you very much for being there. Thank you so much.
Thank you, sir. I think it was a wonderful lecture, and as I can see the questions coming in, people must have understood, enjoyed this session. And thank you very much for simplifying this tough subject into few slides. And we expect the next session to be more interesting than the current one. And thank you, Dr. Sonal, for moderating the session.
Thank you, sir.